So integrative medicine. A doctor who's interested in integrative medicine is not trying to reject a medical model and do something entirely different. So a doctor who's interested in integrative medicine is interested in the best evidence-based but also safe therapies that can be offered. So that's from the conventional medical treatments as we usually think about them, because it's not about discarding all of that because that would be ridiculous, but also a much greater emphasis on the importance of lifestyle. And this is really the big letter issue in terms of what affects affluent countries as lifestyle-related illnesses, but also evidence-based complementary therapies. And we don't get taught much about that, and I'll say a few more words about that shortly. I would say also it's within a holistic approach. It's not just about the body, about the mind, the emotional, spiritual, social, environmental issues as well. So it's a very holistic perspective. And I would say that this is not alternative practice, this is just best practice. The evidence suggests the more specialised we become in medicine, the more narrow the focus and the less interested in lifestyle and other issues a doctor tends to be. I don't think that that's the way it ought to be, but the evidence suggests that that's the case. So we need to be up to date with the evidence, and we need to know what we should be recommending to our patients. This is just the first study that looked at it in the MJA, and this was GPs. And GPs have ever referred for various therapies, and you see that these are the 4 big ones: acupuncture, meditation, hypnosis, chiropractic. So the majority of doctors are referring patients for those therapies at various times, obviously when it's indicated and would be helpful, or the doctor hasn't got other things that they can offer or have practiced. And so acupuncture, nearly 1 in 5 Australian doctors have got training in using acupuncture. The number's probably higher than that now in terms of meditation, but it's probably closer to 1 in 5 now. Hypnosis, vitamin therapy stands out as being a very widely prescribed one, very easy to integrate. But anyway, the point to make is that increasingly doctors are using and advising patients about it. Now, training in complementary and alternative medicine. A study from Australian medical schools suggests that 2 of 13 Australian medical schools at that time had any sort of integrated or significant input from complementary medicine. Monash, where I teach, is one of them, and I'm involved with delivering that part of the curriculum. We'd previously done a survey with our students after forums that educate the students about this, and when the students are actually a little bit more informed and see a bit of the evidence around some of these topics, the majority of students feel, well, yes, that's not difficult to integrate. That is much more likely to have an open mind about these topics. So 9 medical schools had a token reference to it, and 2 of it had virtually no reference to complementary alternative medicine at all. And when we're considering that this is something that the majority of the Australian public are using in their healthcare, to not be informed about it, to not know anything about it, to think it's completely irrelevant to one's medical education, I would sort of think is a little bit surprising. We're not trying to train complementary therapists, but I think that we actually, as a part of modern healthcare environment, we need to know something about it. In US medical schools, 64% offer courses in CAM, and that's up from only 20% in 1992. So certainly it's on an upward trend in the States. The use of complementary therapies, particularly when people are dealing with chronic and severe illnesses, then patients are much more likely to use these therapies. But these are just the kinds of figures that you find. About 3/4 of patients don't tell their doctor what they're doing. It may be that the patient's using other therapies and they don't even think to mention it, or that the patient's had a bad experience in the past when they have mentioned it and thinks, I'm never going to talk about that again. For example, there may be a whole range of reasons, or if we don't include it in our history, we don't ask the patient, you know, you're taking any other therapies, any complementary therapies, any herbs, any over-the-counter products and so on, that we may not actually realise, or the patient may not think to mention it. The commonly cited reasons: people prefer natural treatments wherever possible. Dissatisfaction with conventional treatments. If there's a lot of side effects involved with the pharmaceutical that the person's using, then, for example, I say, well, isn't there something else I can do that's not going to make me feel worse than the actual condition itself? Mostly, patients are not wanting to reject conventional healthcare, but they just don't feel that it's complete. It doesn't cover all of the bases. It doesn't give them all of the options, for example. So looking for something more holistic. Patients who do this tend to be more educated rather than less educated. So they're used to thinking for themselves, asking questions for themselves, want to ask the doctor more questions, want to look wider, look at other sources of information, and tend to have chronic conditions, and also often people have had transformational experiences. And by that is meant, I had a chronic condition, I didn't get much satisfaction or a particular symptom, I tried therapy X, a natural therapy in the end, I tried that, and it made a huge difference. That changed the way I think about healthcare. I'm really thinking about it very different. So it's a transformational experience. I'm just going to give you a couple of examples just to indicate how important lifestyle issues are, and how I think as a health practitioner we need to be taught more about it. So if you take physical inactivity and health, it's pretty much a risk factor for any chronic condition you care to name. That's not a comprehensive list, but that's just some of the conditions. From heart disease, blood pressure, diabetes, cancer, depression, anxiety, osteoporosis, obesity, Parkinson's disease, dementia, we could go on. If you take physical exercise and cancer survival, so I won't use the usual things on heart disease and so on, but what about cancer? Do you think of physical exercise as a therapy for cancer? This is a study on nearly 3,000 women with breast cancer, and they were followed for 18 years. This was published in JAMA. If a woman with breast cancer was sedentary, that was her relative risk of dying from breast cancer over 18 years. Controlled for all of the other factors, if a woman did a little bit of exercise, about a 20% reduction in mortality over 18 years. If she did more exercise, about a 50% reduction in mortality over 18 years from breast cancer, not from heart disease, from breast cancer itself. If that was a new chemotherapy for breast cancer, a new form of chemotherapy would be the biggest breakthrough in chemotherapy for just about, well, certainly for breast cancer and for just about any other cancer as well. And the side effects of physical exercise? Well, better mood, better coping, better pain management, etc. And I could quote you others on prostate cancer, bowel cancer. The ballpark figures for change in survival rates are in the same ballpark. If you look at a recent review in clinical oncology on the 5-year survival benefit for chemotherapy for the 22 major adult malignancies, the survival benefit is roughly 2% across those malignancies. For breast cancer, for example, it's between 2 and 6.9% improved 5-year survival for having chemo compared to not having chemo. Now that's a review in clinical oncology on all of the survival data for chemotherapy. It's certainly not what most of us assume that it is. I don't put that up there to say, oh, that's an argument against having chemotherapy. I just put it up as an indication of how we may often marginalise things that actually may be far more therapeutically beneficial than a lot of the treatments we commonly recommend and assume that we have to use, like chemo. In terms of complementary therapy modalities, and you can see that this is the NCAM classification: biologically based, energy-based practices, manipulative body-based practices, and mind-body medicine. And then around that is whole medical systems. So I'll just say a few things about each of these. So whole medical systems, like traditional Chinese medicine, for example, an integrated philosophy of healthcare, shares various principles like respecting nature's healing powers, that kind of sort of philosophical approach, if you'd say. Mind you, that's not new. Voltaire said something along the same kinds of lines. Many people will use these therapies, say, in the Australian context, not with wanting to adopt the whole traditional Chinese medicine philosophy, but just to use particular aspects of these systems. So Indigenous medicine could be considered as a whole medical system. Ayurveda, traditional Chinese medicine. So these, within their own cultures, are very much embedded in the culture. And they would take all of the elements from different modalities I mentioned before. Mind-body therapies is probably an area where there's a very large evidence base, and there's really not much doubt that your mind affects your body. Your patients know that. We certainly need to know more about it ourselves. These would be all considered mind-body therapies, and CBT, anything that changes your state of mind will change your body as well. That could be considered a mind-body therapy as well. Related fields of science. How many, put up your hand if you're taught about psychoneuroimmunology in your medical course. Put up your hand high so I can see. There's just a few hands. hardly anybody's taught anything about psychoneuroimmunology, how your mind affects your immune system. So the mind, these white blood cells are covered with neurotransmitter receptors. I'm not going to speak at length about it today, but there are textbooks on the topic. There are review articles in The Lancet on the topic. It's been around for decades. Just to give you an indication of how important it can be, for the progression of HIV to AIDS, 2 to 3 times more likely to progress over a 5-year period if there's increased stressful life events, particularly the person is not coping well with, low social support as well. That is, if people's mental and emotional health is not well, it has implications on how fast the progression from HIV to AIDS is. It's not to say it's all in the person's mind, but the mental and emotional health is a significant factor in determining the progression because of its impact on immunity. Again, we could sort of make a similar kind of example around heart disease. Applications of a mind-body therapy like mindfulness, which is one that I have a particular personal and professional interest in. And if you look at all of these clinical applications of mindfulness, there are a lot of reasons why we should be prescribing mindfulness as a part of the management. It's not like a person with HIV or AIDS shouldn't go on to all of the appropriate pharmaceutical treatments that they're having, but it may help them enormously to cope better. And there's some research recently that actually helps to improve a range of prognostic factors as well. But also neuroscience and what we now understand about neuroplasticity produces structural and functional changes in the brain, helps with a whole range of mental health issues, clinical pain management, symptom control. As an adjunctive therapy, a lot of uses of it. If you look at biologically based therapies, everything from nutrition, vitamins and supplements, aromatherapy, essential oils, homeopathy, herbs. So I'll just give some examples there as well. So if a person's got hyperlipidemia, this is a review of 97 randomised controlled trials. The most effective drugs were statins, but the most effective treatment is actually omega-3 fatty acids. So that has the best cardiac-specific and all-cause mortality benefits of any treatment that can be given for hyperlipidemia. If you look at something else, another biologically based therapy like coenzyme Q10 for the management of hypertension, and in the review they found, this is a systematic review, lowers systolic blood pressure by up to 17 milligrams of mercury and diastolic by up to 10 milligrams. So that's looking at all of the studies on this. Again, improved exercise tolerance as well. And for people who are on statins, a lot of the symptoms, particularly the muscle pain, is associated to effects of the statins on coenzyme Q10, so it can help with a lot of those side effects as well. If a person's got particular symptoms like pain or dyspnea, evidence-based reviews suggest that there's a range of different strategies that can help to improve coping with those symptoms. If you look at something like homeopathy, the evidence on homeopathy is not as strong, certainly compared to a lot of other treatments that I've mentioned. So if you look at some of the reviews and a couple of Cochrane reviews, there aren't a lot of really good high-quality trials that have been done, or the best trials that have been done have not tended to support homeopathy as having as strong an effect as we need. You'd have to say that we need more studies in that area, but I do want to just compare and contrast different reviews, different papers on some of these topics. So one couldn't discount it. There's enough to say there might be, some positive studies around, but also there are enough studies to say, throw that into question. So what do patients want? Open-minded and competent doctors. Doctors who are open to questions and communicate well and respectfully, particularly about these kinds of topics. Doctors who can respect their choices, provided they're safe. Respect is important. If a person's making a really ill-advised decision, they need to very clearly get that information from us as well, in a respectful way though. Doctors who have a broader training. Patients would much rather go to a doctor who understands something about integrative medicine than, say, go to a complementary practitioner who doesn't have, say, medical knowledge behind them. Doctors who can help them to find other practitioners and resources, and doctors who can help them to make sense of the science and the evidence around the area. So integrating it into practice, I'd suggest be informed, communicate with your patients about it, respect patients' concerns and preferences, include CAM in your history taking, and make time. If you're going to practice in an integrative model, it needs more time than the kind of 5 to 10 minute medicine that often the system pushes a doctor into practicing. find quality sources of information you can go to, and receive training in modalities of interest. You'll probably need to do that after your medical training, because we don't tend to get much of it during our medical training. Refer patients to well-trained care and practitioners if it's appropriate, and know who in your area you can communicate well with and has got reasonable qualifications and knows when to refer back to you and communicates with you. Continue to monitor your patients. Will be very important from a medico-legal point of view, and keep very good medical records. And do not forego your medical knowledge because you might be using a different approach to the one that most doctors would use. If there's something you really should know about or something you should be picking up, just because you're using something different in the management doesn't mean that you're not meant to know about the medical treatments. And think integrative, not alternative, I would suggest. All right, so if you are interested, as we've mentioned, that's the book, General Practice, the Integrative Approach. As far as we know, this is the first book that's tried to bring all of this together in the one book rather than just having a book on the one or the other. Okay, so we can think differently and think independently, and I hope that you're going to be I really like some of the things that were said earlier today about a healthy scepticism, that you're going to maintain a healthy scepticism through your medical course and through the whole of your medical work in your future, and you can have a broad mind and think for yourself. So that's all I've got to say. I think Kerryn's going to speak now, and then we'll have some time for questions and discussion after that. Thank you.
So I'm going to be talking a little bit about integrative medicine, and I have for some time been calling it the emerging mainstream, because I think that it's not going to be very long before integrative medicine is recognised as the gold standard of medical practice, not just in general practice but across all of the specialties. And what I'm going to be talking to you about now is how we can move the integrative medicine philosophy forward. Now, one of the things that we talked about earlier on was about conservatism and reformism, when we had the panel discussion earlier. And Abraham Lincoln had a view on this. He said, what is conservatism? Is it not adherence to the old and tried against the new and untried? But another view from Ralph Waldo Emerson: we are reformers in the spring and summer. In autumn and winter we stand by the old. Reformers in the morning, conservatives at night. Reform is affirmative, conservatism is negative. Conservatism goes for comfort, reformism for truth. And I think if we just look at that last statement there, that conservatism goes for comfort, reform for truth, I think we can tend to be very, very comfortable in our ruts. And I think that with reformism comes a little discomfort, sometimes for the person who's reforming, but sometimes for the conservatives who are facing reform. And through evidence, I think, comes truth. But evidence, of course, is a double-edged sword. Lunik has a view on conservatism as well, that if you paint in a more realistic style and do some nice, pleasing landscape scenes, we might let you just join one of our proper artistic societies. And having been the president of the Australian Medical Association for 3 years, and now the president of the Australasian Integrative Medicine Association, I have no intention of just sitting around and painting pretty landscapes. The us and them mentality has very much pervaded and been an obstacle to integration of different types of modalities, and I think that there is a human tendency to generalise personal experiences. So as doctors, we quite often have patients that come to us who've been to a natural therapies practitioner, who's missed the diagnosis or hasn't got the treatment right. And natural therapies practitioners that I work with say that they see patients who've been disappointed by orthodox medicine. And of course, being an integrative medicine practitioner, I see people who want a doctor who is informed and has an integrative approach. So I don't think we need to continue to have the us and them mentality. I think what we need to do is to look at skill sets, and we need to look at mutual respect for people who have an adequate level of qualification and experience and an understanding of the boundaries of their capabilities. Now, Craig's talked to you about what integrative medicine actually is, but ideally I think I'd like to see integrative medicine being an expansion of the options available to patients, and with practitioners from different paradigms working in cooperation rather than in competition. But what's also a very important element of this is the thoughtful identification and compassionate use of individual patients' predicaments, rights and preferences in making clinical decisions about their care. Now, this is the person, Sackett, who originally described what evidence-based medicine was, and he talks about respecting individual patients' predicaments, rights and preferences. Now, what we are living in at the moment, at this point in history, is a time where patients, consumers, are telling us that they want an integrative approach in their healthcare. We know that 86+% of cancer patients are using complementary medicines along with their cancer care. If that's not a mainstream movement, I don't know what is. So we're seeing some new and emerging trends. The practice of healthcare is really moving very quickly, very rapidly in transition. Patients are becoming more empowered. There's a rise in self-care, a change in the power base of the therapeutic relationship. People are less tolerant of uncertainty. There's an increase in technology, an increased desire for spiritual dimension to healing in parallel with that increased desire for the latest machine that goes ping. And there's this increasing demand for this thing called evidence, flawed though it might be. I just want to put this up. This is from the therapeutic guidelines in prostate cancer management from our textbook, General Practice, the Integrative Approach. And if you look at your standard protocols for managing prostate cancer, obviously you're going to be looking at, the active surveillance. You're going to be looking at robotic surgery, brachytherapy, external beam radiation, and so you're really looking at radiotherapy modalities, surgery, or nothing except watching and waiting. Organs exist within patients who exist within communities and systems. And if you have a look at the evidence-based advice on reducing prostate cancer risk and managing the adjunctive issues around prostate cancer, you will see things like the Mediterranean diet, low saturated fats, low calorie intake, reducing, eliminating obesity, selenium, where the country has soils that are deficient, high lycopenes, like tomato, adequate vitamin D levels, omega-3 fish oil, soy isoflavones, pomegranate juice, antioxidants like green tea, vitamin E supplementation up to 400 IU. So the reason that Craig and I put this textbook together is that this is the sort of information that you are going to need, because I guarantee you, if you get a patient with prostate cancer, they're going to come into you with an internet search about selenium and prostate cancer, and you're going to need to have answers to have an informed conversation with that patient. They need to avoid saturated fats. They also need to know what not to do. Don't take too much zinc or calcium or dairy products. Don't take excess multivitamins. There are some people, I had one woman this morning who came in with a bag this big, I kid you not, full of the bottles of vitamins and supplements and herbs she was taking. And the first thing we had to do was throw out about 3/4 of them and say, for your situation, once we'd assessed her situation, this is what's ideal for you. So, well-informed professional advice. Coping with cancer. I see a lot of patients who are going through their cancer journey, some of them where they're being screened, some of them have been diagnosed and are looking for an integrative approach, and about 80% of people use at least one form of complementary therapy. A lot of them are self-referring and self-prescribing, and there are dangers in that. The dangers are not just, it might be a dangerous modality for their situation, or they might be taking the wrong antioxidant supplements at the wrong time of their chemotherapy, but they may not be. I think the greatest danger is that they're not optimising their chances of well-being and longevity if they're not exploring modalities that are likely to help them through their journey. We know that some medications will help nausea with cancer treatment, for example, but about 60% still continue to get symptoms. Now, if you're the GP who's sitting there, or the cancer specialist sitting there with the patient, and they say, listen, the wafers you give me don't control my nausea, the injections haven't helped, the tablets I throw up, the suppositories don't help, what do I do next? Don't be the doctor who sits there and say, I haven't got a clue, or I don't know. Be the doctor that says, I know what else we can try. We can try some acupuncture, we can do some guided imagery, we can try some hypnosis, we can look at nutritional support for you. This is the sort of doctor that I think that our system needs in the future. So the future involves an integrated approach to healthcare, and it starts with you yourself as a student. It starts with you as a registrar, and then as a practicing doctor, as a clinician in whatever specialty you go into. Yourself as a role model. Don't be the doctor who smells of cigarette smoke. Don't be the doctor who has the big gut and is really unhealthy and doesn't exercise. Don't be the doctor who's so stressed that their marriage falls apart. Look at yourself and your self-care, and you'll be a better doctor for it. your patients, their choices, self-prescription, the advice that the patients get, that's part of the future of integrative healthcare. The system itself, general practitioners, other specialists, institutions, educational institutions need to embrace the integrative model because it is what is happening in mainstream. At this stage, as Craig said, in Australia, we are not embracing this emerging mainstream, and we need to. And what we need to do is to change the educators and the way the educators are managing the curriculum to make sure that the curriculum reflects what it is that the patients or the medical students are being prepared to treat in the future are well prepared for that particular patient. We need to see a shift in the power base of big pharma so that medical education and postgraduate education is not dominated by big pharma and the pharmaceutical agenda. We need to look at upskilling other healthcare professionals, having registration so that we feel confident to be able to work with other healthcare professionals like naturopaths. Research agenda we spoke about earlier on the panel discussion as well. Research is pitiful, and the government can do its bit with providing support for the PBS and Medicare. So when it comes to patients and consumers, they need evidence-based choice. They need adequate and accurate consumer information. We need informed healthcare practitioners that they can get advice from. They are making lifestyle decisions, but we also need to look at these issues of access and affordability. Education's important. We need to transition our medical schools into an integrative model like many of the major medical schools in the US. We're moving towards that with the AMA-RACGP Joint Working Party, looking at a postgraduate qualification for GPs. I'd like to see that across all of the specialist colleges. And we need to evolve the therapeutic guidelines. At the moment, if you look at the therapeutic guidelines, and I showed you our textbook's therapeutic guideline for prostate cancer, it doesn't look anything like the traditional therapeutic guideline for prostate cancer, and we've done that for as many conditions as we could find evidence for. We need resources. The reason that we wrote the textbook was because there was a demand for resources, and Vicky Kotsarilos et al. Have also written a book, Integrative and Complementary Medicine, which is an evidence-based look. And the AMA conference is coming up, and we'd certainly invite medical students to attend the AMA conference in Manly in Sydney in October. Regulation is moving forward. That's a major issue. Hospitals and institutions need to adopt a new paradigm. We were talking earlier to a clinician from the Mayo Clinic, and he was saying that the Mayo Clinic has really moved to an integrative model, and the hospital is looking to move more towards adopting an integrative model. Now, if you're a patient who is accustomed to herbal medicine, to massage, to meditation, to acupuncture, the hospital is such a culture shift for you. And I see quite a lot of patients spat out the other end, very much the worse for wear. Whereas if they'd taken an integrative approach during their hospital stay, if they'd prepared with pre-rehabilitation and had an appropriate plan for rehabilitation after their hospital stay, things could have been so much easier and better, and their recovery so much quicker. And I think we need to look at including other areas of expertise in hospital teams, especially in the management of chronic disease. For example, why doesn't every pharmacy have a herbalist? We certainly don't train pharmacists to be across herbal medicine, herb-drug interactions. And yet, so many of the patients who are in hospital who are being prescribed for are going to go home and keep taking their herbs. I mean, there was one study looking at the black market, sort of what people were actually smuggling into cancer units in false bottom bags when they came into hospital. People are bringing their own complementary therapies in with them. It's not that they're not taking them. This is just a little bit about how poorly research is funded in Australia for complementary and integrative medicine. And when you compare it with NH and MRC and other sources of traditional funding streams for research, it's just really pathetic how research in this area is underfunded, given the amount of interest that is going on in the community in complementary medicine and integrative medicine. And one of the problems being that the NH and MRC is dominated by non-integrative researchers, scientists and clinicians. Now, the other thing that I just mentioned about evidence is that not everything will ever be tested by placebo-controlled trial, and jumping out of a plane with a parachute is one that was mentioned in the British Medical Journal just not so very long ago, that won't ever be placebo tested. One of the other things that probably will never be placebo tested is something like aromatherapy or massage therapy. There are a lot of things where it's like if it makes somebody feel better and there is no downside, why do we need to put research money into testing it? So integrative medicine, although, as I said, evidence is an important tool, but it's not the be-all and end-all. And particularly, I think, as we move towards an era of pharmacogenomics and pharmacogenetics, we're going to have far more carefully targeted pharmaceutical treatments, and we are probably going to see far more carefully targeted herbal treatments based on your genetic profile. We're already doing that with HIV medicine, with hepatitis C treatment, and with certain forms of cancer, like breast cancers, where we're genetically testing people to see whether particular medication is appropriate for that person. So I think we're really heading into a whole new world of much better tailored, less blunderbuss approach to prescribing. And I think patients are also going to increasingly be demanding a personalised therapeutic approach. So integrative medicine, as I said, is both conservative and reformist. Conservative because it comes from sometimes thousands of years of traditional use and anecdote, and reformist because it really is at this point in time at the cutting edge of clinical and research practice.
Hi, Dr. Hassed had the table with the complementary therapies and the doctors that refer them and have training in them. And I was just curious as to if either of you have received training in either of them, and if so, how often you are called to use your training?
Probably I couldn't pretend to be trained in all of those modalities. I know a few things about, some of the vitamins, a few of the herbs that are safe, and some of the indications. So I don't call myself in any way, shape or form a herbalist. The mind-body area is an area of particular interest to me professionally, and I do a lot of my work with cancer support groups and so on in that area. The lifestyle kinds of issues, a lot of work, MS Australia, Parkinson's Victoria, cancer support groups, etc. A number of patient organisations or patient-run organisations, advocacy organisations for patients are enormously interested in this area. So I'll be speaking to the Leukemia Foundation in a couple of weeks about this sort of thing, and I'm speaking at a health practitioners conference, and so there's a lot of interest. So that kind of knowledge I use a lot in my clinical practice. I'm not as trained in those modalities, and I would often have to refer questions like that. Kerryn's got a lot more perhaps background and so on. She could say a bit about your experience.
We're actually involved in a joint working party with the Australasian Integrative Medicine Association and the RACGP in creating a postgraduate course for general practitioners who are wanting to upskill in integrative medicine. There are a number of courses around the country. I haven't actually done a formal course, to be honest. I've done a lot of self-education, and that's been in spending time with people with expertise in these areas, going to conferences. But I have to say that this is a 5-year work in... this took Craig and I 5 years of trawling through evidence and papers and negotiating with specialists across every discipline because we've had something like 70 contributors across every specialty contributing to this and negotiating with us about therapeutic guidelines and where they were satisfied with evidence. And so I suppose I could call this, my my training module, but I would certainly be planning in the future to be doing more training, whether that's in a formal way or in my own self-directed way.
You would use all of these things in your general practice, doing a lot of consulting in the consulting room. Kerryn be using all of these things, I guess, every day.
Yeah, I do. I have an integrative clinic in Surrey Hills, and so the practitioners I have working with me are a dietitian. We have a naturopath who was trained at McGill in Canada. We have an acupuncturist trained in Australia and China, and who also does TCM herbal medicine. And we have 3 psychologists. So we actually have very high-powered expertise in those modalities. And so I have to be able to speak their language. But I also have a certain level. I know where my level of competence is in, for example, herbal medicine or vitamin therapies or nutrition. And let's say, for example, I had a patient who had had bowel cancer and an ileostomy and had Crohn's disease and, you know, multiple deficiencies, I would get them to sit down for a couple of hours with our dietitian and really go through, and if they had gluten intolerance and so forth. It depends on, you know, how specialised a person's problem is and how tricky the process is. But a true integrative medicine practitioner is aware of what works in what situation and can help tailor a program of therapeutics for a patient, even if you don't deliver it all yourself. I don't do acupuncture, for example, but I have medical colleagues who do within my practice. But I also have a specialist acupuncturist. So, you know, you kind of develop expertise. And the thing is that because of the point we are in history, unless your medical schools start integrating now, you're going to have to do your own postgraduate study in this area.
You've highlighted in your lectures about the strong evidence associated with a lot of integrated and complementary medicine. I was just wondering if there is such strong evidence behind these techniques and treatments. Why are they complementary? Like, why aren't they just part of medicine?
I think that's a really good question. I've tried to highlight, I've given a few examples where I think there is just really good evidence, and I can't come up with a good reason why it's not, why it would be called complementary. I mean, if we develop an idea complementary, orthodox, then we create in our minds an artificial dividing line that our patients don't have generally, and we, as if there's a boundary line, and which side of the boundary line are we on? If we just remove that thinking and just say, what's there good evidence for? What's safe? What's going to be least expensive, least toxic? What's going to fit in with this patient's overall approach the best? And we just draw on we have a whole range of things. Why we imprison ourselves inside a very narrow mentality, I'm not quite sure. But very often we're I spend most of my time in medical education because I wanted to be, help to, bring about some sort of change and reform in these areas. But we're very often being educated by somebody who has a limited knowledge, limited experience, limited interest. And if we think that's all there is, then we take on those limitations and we take them on as fact. There was an interesting review from Grand Rounds in US hospitals of bold statements that were made, and they subjected those bold statements in Grand Rounds, which are the pinnacle of medical education, which junior doctors take on as fact. And there was only a third of those statements that could actually be supported by evidence. Half of them, there was good evidence, but the evidence was the opposite of the bold statement that was made. So I would say for all of us, we need to not assume everything we're taught is so or will remain so in the future, and have a flexibility of mind, and don't create artificial divisions where they don't need to be. So a couple of thoughts there.
People also hold on to what they're comfortable with, where I talked about the comfort of conservatism. And one example, when Craig and I were negotiating the psychiatry chapter, which we wrote jointly with the input of a psychiatrist, he disassociated himself from the book because he did not accept level 1 evidence about St John's wort, which we wanted to include in the therapeutic guidelines. And we had a right old Barney about what was, he was prepared to accept as level 1 evidence, and he rejected the negative studies or the negative meta-analyses, for example, on SSRIs in certain situations. And so we really had to, although his contribution in terms of the earlier part of the chapter was very helpful, when we saw where we came up to a barrier. And so on the one hand, people do tend to hold on to their conservatism or what they know and don't like change, resist change, even when it's glaring them in the face. And you heard from Robin Warren earlier on about where here are these bugs, they are here, and the medical paradigm at that time said there is no bug. And now it's like, oh yeah, duh, H. pylori. But it wasn't always so. And the other thing is a thing called lag time for adoption. Now, the evidence on fish oil and secondary prevention of heart disease has been compelling for quite some time. And yet I was facing, up until about 4 years ago, patients coming back out of hospital from their specialist being told to stop taking their fish oil after they'd had, their heart condition monitored in hospital. And it's only, you know, I started printing off and sending monographs on fish oil to some of these specialists, and eventually the specialists started prescribing it like it was their idea. And so there is this lag time for adoption, and it's all about the process of change. And I think sometimes it's hard to be patient when you know.
I'll just briefly add a quote from Schopenhauer, who was one of Einstein's contemporaries when the paradigm around physics was changing 60, 70 years ago. And it goes along the lines of, in the discovery of any truth, it goes through 3 stages. In the first stage, it is ridiculed. In the second stage, it is resisted. In the third stage, it is taken as self-evident. And I think that anything that changes our way of thinking goes through those kinds of stages. So,
we've got one final question.
With a lot of conventional treatments, the safety and the efficacy are highly operator dependent, particularly with procedural interventions like surgery. If you're a GP referring someone for surgery, let's say, there's a system in place for making sure that at least we think this person is good at what they're doing, in that they have to pass a fairly rigorous training program and they have to go through these surgical audits and so on. If I'm a GP in the community and I'm thinking of referring someone for, let's say, CBT or what, any of these other long list of things you've mentioned, how do I tell which person that I might refer this person to knows what they're doing and is good at what they're doing, and which ones don't?
Well, from a clinician's point of view, and I work as a GP in the community, some of it's word of mouth. You might get a patient coming back saying, oh, I saw this psychologist and they were absolutely amazing, and you'll make a note. I sometimes will ring them up and suss that person out. I check out qualifications. We have registration systems for a lot of the allied health professionals, and you hope that those registration systems, similarly to the surgeons, will pick up, will ensure continuing professional development and a baseline level of qualification. Where we run into difficulty is, let's say, for example, traditional Chinese medicine. In 2012, that will become a registered specialty in Australia. It's been in Victoria for some time, but it's going to be Australia-wide under APRA, I think, in 2012. The naturopaths are working on a process of self-registration at the moment. They would like to have registration. That makes it difficult. You actually have to really be a bit in the know about the particular practitioner. But where there's registration, it makes it a whole lot easier. And then it's like for example, I wouldn't send, there are certain surgeons that I will send patients to for particular conditions that I wouldn't send for other conditions, for example, because you kind of get to know what people are good at and what their interest is, or they let you know. And I suppose it's the same with the allied health professionals. Certain physios I think are fabulous at shoulders, and others are better at necks and low backs, you know. So you just kind of get to know through experience, but also asking your colleagues. If you've got more experienced colleagues, you know, you can always ask them who they use to refer to for particular situations.
I'd agree with everything that's been said. I would also say, in conversing with that person you're thinking of referring to, particularly if they're non-medically trained, wouldn't be one of the usual kinds of allied health professionals we'd work with, is to make sure that, that you're not going to never see the patient again, that you're going to monitor them, that they're not going to undermine the management that you've already got with the patient on, that you're going to keep good records, and that you need to be confident the person you're referring to is a reasonable practitioner, and that you are monitoring and doing something that has some reasonable basis medically, you know, that there is some kind of evidence, or at least it's safe for what you're doing. Because potentially, if you do something that would be, for which there's no evidence, for which is a very questionable treatment, to a practitioner of questionable qualifications who doesn't, and you don't monitor well, you could be medico-legally potentially at risk for not doing something that is responsible. So I think that there are a few issues that we need to take carefully if we're going to be referring to a non-medical practitioner complementary therapists, for example, for further advice and recommendations. So I think that there are some medico-legal issues to consider as well for that. And yeah, we discussed that in the book too, because it's an important issue for clinicians.